Good afternoon, everyone. COE MAMC welcomes all the participants for today's RDLS session. Today's topic is family-centric approach at ART centers, and the speaker is Dr. Sachin Kataria. Dr. Sachin Kataria, sir, is currently working as a senior medical officer with the Center of Excellence at Maulana Azad Medical College, that is MAMC, New Delhi. He has done his postgraduate advanced course in cardiac management from the University of Boston. He has completed the certificate course in clinical management of HIV from the University of Washington. We welcome you, sir, for today's session and request you to start the session.
Thank you, Shweta ji. Should I open the PowerPoint or you will manage?
So the screen is visible.
Okay,
Yeah. You'll have to just change the slides from your end.
right. Good afternoon, everyone. Today we will be sharing some thoughts on family-centric approach at the ART centers. Uh, so the WHO recommended guidelines says the family-centered HIV care model have emerged as an approach to deliver comprehensive care to all HIV positive family members together rather than the individual care. The family-centered care impact improves the retention, ART adherence, as well as the viral load suppression is done. Sorry. Okay. The studies provide evidence that the family-centric package of care increases HIV testing for the partners and children of patient enrolled in care and treatment services, which increases the access to care, that is the index testing. It manages the family unit through a single point of engagement, and it improves retention in care by reducing the number of visits. The problems and the observations that are observed at the ART centers are the proxy visit. It is about 20% of the footfall in Northeast and high load centers. Who are these proxies? It could be friends, neighbors, family members, workplace colleagues, or it may be relatives or any other person. The family member is also treated as a proxy, which is a lost opportunity. Actually, it is a treatment supporter as a proxy, which could be spouse, partner, or child. The high treatment interruption and viral load unsuppression in children and adolescent includes the factors: potential misclassification of family members for pill pickup as proxy, lack of family IDs, which could be missed opportunity to ascertain child's clinical details, which could be weight, symptoms, etc. Another factor includes potential subtherapeutic doses, alignment of pill pickup dates, and decreased clinical visits of stable family members. The family-centric counseling and positive prevention messaging includes missed opportunity for family counseling, index testing, and treatment and prevention message from the family unit. Shweta ji, can we hide the upper part somehow?
Yes, sir. If you can see on that floating this thing,
Okay.
there are three dots at the end.
Uh,
At the bar that you
okay,
are
I
seeing
got
at
it.
the top,
Thank you.
there are
Thank you.
three dots. Yeah.
Yeah. So the potential or intended benefits from family-centric model of care include reduced travel cost and time. It facilitates the disclosure of HIV status among the family members and thereby improving the adherence of ARVs. It also improves retention of patients on ART with the help of the treatment supporter. It also facilitates HIV testing of untested clients, which includes the index testing. It facilitates early screening of any non-communicable diseases that runs in the family, and it also reduces the footfall at the ART centers. The operational definitions include who are the family members. It is a group of two or more persons with HIV related by birth, marriage, or adoption who live together and their sexual partners, and all such related persons who are ready to support each other for HIV care and treatment are considered members of the one family. Family unit comprises of all the members of one family. The stable PLHIV, as per guidelines, the stable patients are defined as on ART for at least 6 months, no adverse effect of ART that requires regular monitoring, no current illness or OIs or any other medical condition which requires management or regular monitoring, and suppressed viral load. The family-centric package of care includes identification of the family members and units, alignment of due dates of all family members. It also includes their index testing, family counseling and assisted disclosure support, followed by initiation of ART to all the positive members of the family, followed by a refill of ARVs and prophylactic medications, followed by all family members living with HIV are seen together in the ART Center for Services as a family unit, followed by adherence assessment of all family members, family-centered adherence support to engage as treatment supporters, followed by education on patient adherence and treatment and the viral load literacy, and lastly followed by referrals for other services which could include social schemes, nutritional support, family planning, and NCD, etc. The package care includes orientation, consent, stamping, and folder organization, followed by due date alignment for pill pickup by any family member, supported by index testing of children and spouse, followed by TB screening and TPT, which is followed by a screening of NCDs, supported by facilitation of disclosure of HIV and adherence support engaging the caregivers, and lastly, family counseling and support, which has four comprises, which includes the identifying families, alignment of due dates, family-centric care, and the monitoring and follow-up. Now we'll go step by step through the process of implementation of family-centric care package, which includes identification of family members and units. Please respond in chat regarding the question that are you aware of the number of families coming to your ART centers of the total alive on ART? Please answer whether it is yes or no.
So
Okay.
we are getting responses in the chat box.
Yes.
Yes.
Out of 21, only 2 people have answered till now.
Okay. Yeah, requesting participants to please put their responses in the chat box. Uh, 3 people have responded, sir.
Okay. I think we'll continue. Okay.
Yes.
The next step for the implementation would include question number 2, that please state in the chat box how you can identify family units as a part of routine care at ART centers. Please respond to the question, please.
Kiran, sir, can we give mic access to everyone for COE, MAMC, RDLS?
Yeah.
Yeah. Participants can now unmute and they can answer. keeping white card of families together, giving the same next due date to all the family members. Thank you, Dr. Harshita ma'am. So can you please share the so can you please start sharing the screen again?
Should I continue?
Yes, sir, please.
Okay, we'll just take a review that how can we identify the family members and units. The ART staff identifies the family members as per the details in the patient treatment and white card. The staff reviews the family details from the white card section 3. The counselors actively ask each PLHIV for the family details and records, the same if the detail in the white card are incomplete, and routinely PLHIV family status needs to be updated as and when required. The identification of family members and units, creating a family ID includes creating a family ID which is marked by a blue color in this, which is, for example, is F272-02, which includes the ART numbers of the family members, which is marked in the box. F272 denotes the number of the family unit, and the 02 number denotes the number of family members in the particular family unit. Each family's medical record are arranged in a separate folder. They are labeled by family ID and the ART number of the family members, and same on the patient green book for easy retrieval and retrieval of the records whenever they visit the ART center. Step 1 would include the response from your chat regarding the family members and units. The question 3 is following family ID was given by the ART center 0234-03. In this, what does 0234 denotes? Please respond in your chat box. What does 0234 denotes? Uh, we'll just go back with a slide. I think there is some confusion because it is not the family size. It says the first part is the family unit and the second part is the number of the families. DDU has answered correctly. So it is supposed to be number of family units in the center, followed by the family size, which is the number that is 03. Another question is following family ID. I think I have answered the 03 part. It is the family size. Okay, alignment of pill pickup due dates. Review the due date of visit from section 13 of the white card for the members in the identified family unit. Align their due dates to ensure that the family has an agreed single due date of visit. And while adjusting the due date, ensure that the pills in hand are accurately taken care of. Actively ask the family members their feasible dates of visit based on occupation, schooling, and other socio-demographic conditions. Ensure that the details are recorded in the white card as well as in the green book. Offer index testing services. Actively ask for HIV status and testing details of the family members, which is marked in the section 3 of the white card. Seek information on biological children and family members, testing details. Seek information on other sexual partners and their testing details. Referral for HIV testing. For a HIV positive index client, it includes spouse, it could be male, female, or TG, sexual partners, injecting partners, or biological children, because the potential exposure is the key. If the index client is less than 19 years, then the biological mother is tested for HIV. And for all biological children less than 19 years tested for HIV, if the mother is HIV positive or father is HIV positive, and report the child's mother is HIV positive, deceased, or her status is unknown, or the biological sibling if the index case is a child. During the initial visit, counselor assesses the family members and provides the following: the disclosure of HIV status to other family members or partners, initiation of ART to all the positive members, adherence counseling, counseling on psychosocial issues. During the visit, ART counselor tries to analyze reasons if unstable on ART and provides counseling accordingly. Assess stable or unstable members. Family-centric package of care. The process follows patient visit at the ART center, followed by a care coordinator who collects the patient's treatment cards of all family members and creates a family folder. Counselor or staff nurse has to verify the family details from the routine program records, align pill pickup date of the family unit, assess ART adherence of all family members, informs on the concept of treatment support, treatment buddy, encourages index testing of spouses, sexual partners, and biological children, assist disclosure, verified HIV viral load status, and their results, followed by screening by the medical officer who determines the status, whether the patient is stable, unstable based on the national guidelines. Clinical reviews done for opportunistic infections, no major toxicity to ARVs, CD4 more than or equal to 350, no immunological failure, willingness for MMD or the multi-month dispensation, reviews the viral load count and need for any referrals, followed by the data manager who gives the unique code, and the data manager writes unique code on the white card and green book, update the family member details. Lastly, followed by client goes home and returns for follow-up on the rotation basis on the due date. Now the log frame for FCC includes preparation, implementation, and outcomes. Preparation includes identifying families, introducing the concept, obtaining the oral consent, collecting the ART numbers of other family members, FCC stamping on white card and green book, segregation of white cards, updating the details in the MLL, generate family ID, folder preparation with family ID, orienting the family as a unit on the FCC concept and benefits and their role for implementation, aligning the due dates of all members, ensuring that one family member collects the pills for the family, family members start collecting pills for other members, identifying the need of the family members and provide need-based services and referrals. ARTC staff focuses on unsuppressed family members, index testing of eligible family members. All the family members visit ARTC once every 6 months. Outcomes include due dates of family members aligned, reduced clinical visit of family members, improved retention of PLHIV in the FCC, improved viral load suppressions, reduced footfall at centers resulting in enhanced quality of care. Now, the demonstration of family-centric package in Nagaland State AIDS Control Society, which has been done at 2 centers, includes since February 2022, with the approval of Nagaland State AIDS Control Society, FCC implemented in 2 high-load ART centers over there at Kohima and Dimapur district, which contributes to 60% of treatment interruptions in the state. So Dimapur includes 4828 PLHIV, 51% of the total PLHIV load in the state. And Kohima includes 1738 PLHIV, 19% of the total PLHIV load in the state. And when initiated in FCC, you can clearly see what was the difference. This is the depiction for the demographic and clinical characteristics of PHIV enrolled in family-centric package in Nagaland. Uh, the age group, the gender, typology, duration of ART 4 years, viral load count copies per ml at the time of enrollment, members in the family unit, and the composition of family unit. It clearly shows the percentage variation also. So the outcomes for FCC Nagaland included viral load coverage of N being 899 includes at enrollment into FCC it was 613. After 12 months of enrollment it was 627 and the P value was 0.475. VLC 2-member family units N was 783 of which 546. At 12 months it was 549. VLC more than 2 members family unit included N, which was 116. At enrollment, it was 67. At 12 months, it was 78. Viral load suppression, N was 899, of which 515 at enrollment, and at 12 months, it was 568. VLS, 2-member family unit, N was 783, which at enrollment was 466, which increased to 501 at 12 months. More than 2 family member unit, N was 116, of which 49 at enrollment and 67 at 12 months. And the treatment continuity, enrollment was 895. At 12 months, it was 843, which was 0.001% p-value. Response from PLHIV for family-centric package of care supports in the family bonding was 100%. Reduced frequency of visits to ART center was 100%. They spent less time at ART center, which was 100%, which was reduced travel expenses was 99%. They were able to tackle family issues more than 99%. Had issues in disclosure of status to family, it was slight lesser, about 74%. Received good care of children, 100%. Happy with the quality of counseling, it was 100%. The color marcation varied from white, agree, neutral, and the purple was disagree. Demonstration of FCC at Andhra Pradesh State AIDS Society. FCC outcomes was from April 2023 to February 2024 identified 1708 families accounting for 27.4% of the PLHIV accessing ART from the 2 ART centers. The majority 94%, which was 1605 of 1708, were part of the 2-member families. Pill pickup dates were aligned in 1491, which was 87% families registered. After 3 months of FCC, VLC was 57%, 66 of 161, and 84%, 687 of 819. Viral load suppression was 86%, 57 of 66, and 91%, 625 of 68. Among more than 2 members and 2-member family units, respectively, the difference in VLC was significant among 2-member compared to more than 2-member family units. It differed to 27%. 6 months retention has increased from 94% to 96% retention among the PLHIV from FCC. The FCC challenges and learnings were challenges were storage space for keeping the folders, patient leaving the folders aside and carrying white cards only at ART centers in the initial phase, retrieving white cards during initial visits as there will be no family ID on the records, be it white cards and the folders. The learnings were though it is some sort of burden on all the cadres in the facility at the initial stages. It can be sustained with the support of treatment partner staff at the facility level. The learning also was taking the support of CSCs and OVC partners will be an advantage to lead the activity towards sustenance. The conclusion was based on the preliminary findings, streamlined patient visits, reduced ARTC load, and eased healthcare provider burden with minimal financial resources. The family-centric package of care can be scaled up to other ART centers. Testimonials from beneficiary included. Family-centric approach has aligned all my family members' due date and allows a single family member to visit ART center for collection of ART drugs, thus lighten the burden of visiting ART center frequently. Today, I picked the ART drugs for all my family members. Now I have much clearer idea about my child's regimen. Another testimonial was, now we are allowed to collect ART drugs for all the family members. We don't miss dosage like we did before because all of us had different due dates and found it difficult to visit ART time and again. Excuse me. One night I forgot whether I took the ART pill or not. It came to my mind that me and my spouse share same due dates. So I checked her remaining pills and checked mine too. As a result, there were one extra pill in my bottle, which confirmed that I missed to take the pill. Another testimonial includes me and my family lives in an outskirt of town, and it is hard for us to visit ART due to financial and transportation obstacles. But enrolling in FCC helped me by not letting us visit ART on and off. Another testimonial was when visiting the ARTC counselor educates me on when each of my family members should do a various clinical tests. Now I know the due date of my spouse's clinical test. The FCC package to enhance treatment continuity, support stakeholder consultation, including community members, develop SOPs on the patient flow and monitoring tools, capacity building of ART center staff and community, on-site supervision, mentoring and monitoring support, thus following to adherence to operational and clinical SOPs and data quality. The outcomes include scale up and amplification, which started as a pilot in Nagaland in 2 sites in financial year 2022 and scale up to 15 sites in Northeast by the financial year 2024. The results from pilot in Andhra Pradesh, the FCC piloted in 2 ARTCs in 2023, which scaled to 4 sites in 24. 3560 families enrolled, which is 23% of the treatment currently. Retention at 12 months is 96%, which is 1966 out of 2046. Viral load coverage increased from 72% to 96%. The viral load suppression improved from 87% to 94%. There was more sustainability. No additional staff was required. Key was simple calibration of patient flow and ease of record keeping. The family clinical and adherence self-reporting tool includes ART number, relationship, date, weight. Has the patient missed any dose of ART in the last month? If yes, how many? Any other complaints or symptoms? And next due date of visit. MLL, I think everybody knows, so I don't need to revise it. You can just have a look at it and then we'll move forward. We have acknowledgements from Nagaland SACS, AP SACS, DAPCO, District AIDS Prevention and Control Unit, and the ART Center staff. Any queries? Any queries? Shweta ji?
नहीं सर, चैट बॉक्स में तो नहीं है सर. Any
हाँ जी.
queries from the participants? They can now unmute and ask questions. किसी के कोई भी सवाल हो फैमिली सेंट्रिक अप्रोच को लेके तो प्लीज आप सवाल पूछ सकते हैं. माइक एक्सेस सभी को दिया गया है. आप चैट बॉक्स में भी अपना सवाल डाल सकते हैं. So I don't think there are any questions. Thank you so much for facilitating this important session.
Thank you, Shweta ji.
Thank you, sir. Requesting all the ART centers to please join the RDLS session at 2 o'clock whenever it is planned. You receive emails from COE MAMC or PCOE KSCH for the RDLS session. Please see to it that you join at 2 o'clock. Thank you so much, everyone, for joining in and patient listening. We'll conclude the session now. Yeah, sorry. There's a feedback poll. Please attempt the feedback poll. Thank you, Kiran sir. देर आर 5 क्वेश्चंस इन ऑल. एक बार स्क्रॉल करके सारे क्वेश्चंस के आपको आंसर्स देने हैं. जो भी आंसर आपको करेक्ट लगे आपको बस उस पर क्लिक करना है. द फीडबैक पोल इज नाउ विजिबल ऑन योर स्क्रीन. Scroll through the questions and answer the select the answers of your choice. Requesting all the participants to please attempt the feedback poll. Kiran sir, we can end the feedback poll now. Thank you, everyone. Thank you, sir, once again. Sir, we'll conclude the meeting now.